in for a really nice treat here. Uh, Wes Tuckler is not only is an expert in the area of diet and nutrition. He's working in the areas of stroke prevention, but he's a great speaker and really gives quite updated information based on the data. And so really looking forward to it. Thanks so much, Wes, for taking the time, and really looking forward to this talk.
No problem. Thank you so much for inviting me. Can you see the slide, Sean, just to double check?
Yeah.
Okay, cool. Well, thank you for your kind words, and no pressure now in terms of making a good impression today during the talk. So, first of all, thank you to everyone for joining this talk and listening in. The title of this talk is Make America Healthy to Prevent Stroke. We're going to focus on nutrition and dietary interventions in particular. Sean picked the title, so if you're in some way offended by it, then you can blame Sean. So I am an associate professor of nutrition at Texas Women's University, right down the road in the Med Center. And just some quick disclosures here. No conflicts of interest to disclose. I'm going to show certain foods, foods and supplements that we used in our recently completed pilot study. Those are not an endorsement of those products. I'm just showing them purely for educational purposes. So here is an outline of my talk. It's basically going to be broken down into three sections. The first part is basically just a quick kind of overview of the scientific literature. So if you saw my talk 6 months ago, I think it was almost 6 months ago to the day, it's going to be a lot of kind of a recap or a summary of that. So it'll take about 10 or 15 minutes, but then we'll and that'll include the best diets for primary prevention of stroke, and then also the best diets for brain health as we age, or for the prevention of neurodegenerative diseases. And then I'm really excited to share some preliminary data from our research lab. We just finished a pilot study using the MIND diet with high intensity interval training, so a diet and exercise kind of lifestyle intervention for patients with hypertension. So I will share some of the preliminary data. You're the first group in the world to actually see this data. So please feel free to give us feedback, criticism. We're probably going to get criticism anyway from reviewers. So, definitely open to feedback at the end during the Q&A. Obviously, with any sort of pilot study, we're interested in, feasibility and adherence just as much as we are with actual, changes in outcomes. So I'll report some of the, feasibility kind of metrics, and then also the changes in blood pressure, both clinic and ambulatory blood pressure outcomes as well. And then just some lessons learned, insights, and then limitations that we probably will need to address if we want to actually implement this in the clinic or in the community going forward. And so that's going to be kind of the final part of the talk. It's only one slide, so I apologize in advance, and that's not the area that I'm most qualified in. I definitely need collaborators in public health so to help me with that aspect. So but I think it'll be a good discussion nonetheless. Okay, so the first part of this talk is going to be nutrition for primary prevention of stroke and neurodegenerative diseases. And so when we think about the best diets for reducing the risk of stroke, it is very similar to the best diets for reducing the risk of myocardial infarction or heart attack. So it's going to be your Mediterranean diet and your dietary approaches to stop hypertension, or the DASH diet. Those are the two diets that have the most research on them, and they pretty consistently show a significant reduction in stroke risk, with close adherence to either of these diets. Now, what is the Mediterranean diet? Well, it is just a diet that incorporates traditional cuisines from countries that border the Mediterranean Sea. It emphasizes plant-based foods, whole grains, vegetables, legumes, fruits, nuts, and seeds. So a lot of plant-based proteins, primarily fish, chicken. And then the main source of fat, and this is important because, it's going to come up again in our study, but, the main source of fat in the diet is going to be extra virgin olive oil. And so a lot of the benefits are thought to be attributed to extra virgin olive oil in particular. And also, this diet avoids processed foods, red meats, and added sugar. So not only does it emphasize foods that are associated with good outcomes, biologically active compounds that are associated with beneficial outcomes from a CVD risk standpoint, but it also avoids the foods that are associated with negative outcomes. Now, one thing I always want to mention as well, and the reason I bring this up is because this is the one way that does differ quite significantly from the DASH diet, is the Mediterranean diet is not a low-fat, a low-fat diet. I mean, it's, if anything, it's a moderate, carbohydrate diet, and then it's almost a high-fat diet in many ways. I say that carefully because I don't want to call it like a keto diet, because it's not. It's totally different. But it is very common to see a macro breakdown with a Mediterranean diet as much as 30 to 45% fat. Okay, so beneficial dietary components, and I've already mentioned some of them, but first of all, the most important thing, and I'm going to reiterate this point when I show you our data, is there is a very, very high overall diet quality. I think people like to get hung up on, oh, it's the olive oil, or it's the nuts, or it's the, it's the dark green leafy veg. But the reality is that this diet has a very, very high overall diet quality just in general. It's high in fiber, antioxidants, micronutrients. It's low in sodium, saturated fat, trans fats, and added sugars. So, it restricts those foods that are associated with negative outcomes. It's high, and then this is probably one of the most important aspects of the diet. It's really high in mono and polyunsaturated fats, and those are going to be your healthy fats that are typically associated with, lower inflammation and better cardiovascular outcomes. So, and this is because of the abundant use of olive oil. So one fatty acid in particular, oleic acid, which you can actually measure in the blood to look at compliance. We did not do that in our study, but that probably would be one critique that you could have for our initial work at least. But you can measure that in the blood to actually look at adherence to a Mediterranean diet, would be measuring oleic acid. And then fish and nuts are also highly prevalent in the diet, and as most of you know, those foods are typically associated with better outcomes as well. All right, and then extra virgin olive oil does contain several bioactive polyphenols, which are typically associated with reduced inflammation. So does the Mediterranean diet reduce the risk of stroke? Well, a 2016 meta-analysis pretty consistently showed that, looking at 3 randomized controlled trials, so one of the criticisms with any sort of nutrition or dietary work looking at outcomes is that a lot of it is maybe prospective. It's not randomized controlled trials. This is the one exception where we feel pretty confident the Mediterranean diet does reduce the risk of stroke, because randomized controlled trials consistently show that it does. So it's associated with about a 35% relative risk reduction for stroke, and this is when you include 3 studies and over 9,000 patients. Now, the one study that it basically heavily focuses on, and I think this makes up about 70% of that meta-analysis, because this study was called the PREDIMED study. It was published in the New England Journal of Medicine in 2018. It was a multi-center randomized controlled trial in Spain between 2003 and 2011. It had almost, had roughly 7,500 participants, so really large sample size. Again, multi-center across Spain. And what they were looking at is they were looking primarily at primary prevention. So does following a Mediterranean diet over the course of several years actually reduce the risk of cardiovascular events? So a very, very hard endpoint, cardiovascular events versus some of the, softer endpoints that are typically associated with nutrition studies. So the primary objective was to test the efficacy of these 3 diets on primary cardiovascular prevention, so heart attack, stroke, or CVD mortality. So major adverse cardiovascular events being the composite. So Mediterranean diet, they had 3 groups: Mediterranean diet plus olive oil, Mediterranean diet plus mixed nuts, and then finally a traditional low-fat diet. So, think about this. Back in the day, AHA actually used to promote a low-fat diet as being the optimal diet. So around this time, people were still being told to kind of, follow a low-fat diet for optimal cardiac health, and they actually used that diet as the comparison group here, was their control group. So this kind of even further strengthens the quality of this data. So when you look at the results of this study, you can see pretty clearly that if you look at the cumulative incidence here, and this is over a 5-year period, those following the Mediterranean diet with either extra virgin olive oil or nuts had a 30% lower relative risk of having a major adverse cardiovascular event compared to following a low-fat diet. So a pretty significant reduction, and you can see the separation really early on after a couple of months actually in terms of outcomes, and that just consistently stays all the way up until 5 years. Now, one thing that I want to mention as well is it's important to note, especially in the age of GLP-1, that these reductions in risk were almost exclusively independent of changes in body weight. So I say this because, I'm a huge GLP-1 fan. I think it's an incredible drug, and it leads to incredibly huge improvements in outcomes and obviously clinically significant weight loss. But I think that one thing that sometimes is lost is that exercise and diet have incredible benefits completely independent of changes in body weight. And so that's kind of a point that I want to reiterate throughout this talk today. So what about stroke risk reduction by itself? Obviously the study by Estrup and Predimed was major adverse cardiovascular events, but that doesn't look specifically at stroke. So the data for stroke alone was even more promising. So Mediterranean diet plus extra virgin olive oil led to a 35% risk reduction for stroke. And if you look at the Mediterranean diet plus nuts group, a 46% reduction in the risk of stroke. So the take-home message here is that the Mediterranean diet, supplemented with either extra virgin olive oil or nuts, was associated with a major risk reduction of major adverse cardiovascular events and stroke by itself in at-risk adults. And this is just in terms of, I always think I'm an applied physiologist, so I always think about mechanisms. I always think, well, that's great. Like, that's a major risk reduction, or that's a major improvement in blood pressure, or that's a major improvement in a CVD risk factor. What are the mechanisms that are actually driving this risk reduction? And so when you're thinking about, atherosclerotic cardiovascular disease, obviously plaque progression is a major issue, especially in this kind of at-risk middle-aged to older adult population. And so this is just some data from Jimenez Torres that was published in 2021 in stroke. And this basically this was the CardioPrev study. So these are individuals who have existing cardiovascular disease. But the really cool thing in this study was they used, carotid IMT to basically look at, plaque progression over 7 years. And they actually showed that if you closely follow a Mediterranean diet, you can either slow or reverse some of the plaque progression in some of these, at risk or adults that have existing cardiovascular disease. So this might just be one of the mechanisms as to how the Mediterranean diet is reducing this risk of major adverse cardiovascular events. So that's the Mediterranean diet, and so it's pretty clear that one is a good one to follow if you want to reduce your risk of stroke. Another one that has really good clinical evidence as well is called the DASH diet. Now, the DASH diet's been around since 1997, I believe was the first study, published by Lawrence Appel. And so there's been several really well-controlled studies since then, and the efficacy is really good as well. Now, the composition of the DASH diet is going to be a little bit different to the Mediterranean diet. It's a more higher carbohydrate diet, lower in fat, so it's a low-fat diet, low in fat and saturated fat. It has high amounts of dietary fiber, potassium, magnesium, and calcium. It has a mild sodium restriction, but you can also give someone a low sodium DASH diet. It is actually really common. And I think that, the NIH actually recommends that they restrict sodium as well now. But initially, it wasn't really a major sodium restriction, but that has kind of changed over the years. The major benefit of this diet is a little bit different in the way that it works mechanistically. So the belief here is that the major reduction in blood pressure is associated with an increase in the potassium to sodium ratio. Usually the Western diet, as we know it, if we eat really unhealthy, we eat a lot of processed foods, we eat a lot of sodium, maybe 4,000 milligrams a day, and we don't eat a lot of potassium. So ultra-processed food does not have a lot of potassium in it. And so basically getting people to eat more whole foods, less processed foods, follow a DASH diet. Now you're increasing the amount of potassium and you're lowering the amount of sodium, and that by itself is associated with the reduction in blood pressure. So the DASH diet does lead to clinically significant reductions in blood pressure. This is pretty crazy. I always show this data and I have to kind of remind myself, this is just 30 days. So just 30 days of following this diet, the DASH diet with low sodium. So all this figure on the left is showing you is that this is basically varying levels of sodium. So they're looking at the DASH diet by itself. And then what if we use the same DASH diet and then we restrict sodium in addition to that? So different dosages of sodium. And you can see that just the DASH diet by itself leads to about a 7.1 millimeter of mercury lower reduction in systolic blood pressure, and the same for or a nice reduction here for diastolic as well. And again, this is just 30 days, but this is in patients who are not on pharmacotherapy. So that's an important point as well. So these are individuals who have elevated blood pressure, or they're probably pre-hypertensive to begin with. They weren't on meds, and they just go on this DASH diet for 30 days, and they have pretty significant reductions in blood pressure. So adherence and also the adherence to a DASH diet is associated with a pretty large reduction in risk. And so this is just a meta-analysis of 12 prospective cohort studies of over 5,000 participants with a follow-up duration of over, up to 24 years. And compared to low adherence to a DASH diet, higher adherence is associated with about a 12% lower risk of having a stroke. Okay, so let's pause for perspective real quick. I just like to do this. So this is kind of the midpoint of the part one of the talk. So just to go, in summary, Mediterranean diet clearly lowers the risk of major adverse cardiovascular events and stroke in at-risk adults. The DASH diet leads to clinically significant reductions in blood pressure, and high adherence is associated with the lower risk of developing stroke. If you wanted to say which one has the best scientific evidence, it would be the Mediterranean diet, just because of the aspect that it has the sample size of people in randomized controlled trials. Okay, so what about nutrition for the aging brain and the prevention of neurodegenerative diseases? And the story here is pretty similar. What is the best diet for preserving cognition and reducing the risk of neurodegenerative diseases? It's the best evidence that we probably have is going to be in two different diets, the Mediterranean diet and then the MIND diet. Now, when we look at the Mediterranean diet, this is just a case study between two different patients that have basically been on the Mediterranean diet all their life versus the Western diet all their life. And again, you guys can correct me at the end of this talk. Me walking people through a brain MRI is pretty frightening. So my understanding is that if you look at the image on the left, on the Mediterranean diet, the patient has small, compact ventricles, which is a good outcome, versus the person on the Western diet on the right has large, enlarged ventricles. And then if you look down here at the hippocampus, on the image on the left, they have a well-rounded and it's in close contact to surrounding tissue, versus the one on the right who's on a Western diet. You can see that it is not. It's more disrupted. And then over here where this arrow is, where they're talking about the Western diet, you can see in the temporal lobe, you have signs of atrophy in that brain that's been on a Western diet their whole life. Now, this is obviously just a case report or case study. One person on a lifelong Mediterranean diet versus another person who's on a Western diet, and there's obviously other confounders that could impact this brain imaging as well. But there are a lot of studies now that show that even randomized controlled trials where people get prescribed to a MIND diet or Mediterranean diet, typically the brain outcomes are a lot more favorable when they get prescribed the Mediterranean diet or the MIND diet, and that includes less brain atrophy with aging, and then also a reduction in those white matter hyperintensities that you typically see on image scans as well. And then, in terms of cognition outcomes, I think this is actually from that same PREDIMED study. So they just looked at over time, over that same kind of 5 to 7 year period, they looked at if people were on the Mediterranean diet with extra virgin olive oil or nuts, was that favorable for memory, frontal cognition, and global? And you can see here that consistently it appears that these diets either maintain or improve cognition over time, versus on the controlled diet, now you have kind of the effects of aging associated with a decline in memory, frontal cognition, and global cognition as well. Okay, so that's the Mediterranean diet. Now, the diet that we're going to talk about pretty much for the rest of this lecture is going to be the MIND diet. Now, the MIND diet is the Mediterranean DASH intervention for neurodegenerative delay. Now that's a mouthful, I know. So we're just going to say MIND diet for the rest of this talk. But so what is the MIND diet? Obviously, this was a researcher at Rush University in Chicago back in around 2010, I believe, came up with this diet, and they had this really genius idea actually to combine all of the good elements of the Mediterranean diet, all the good foods that are associated with the health benefits of the Mediterranean diet, merge that with all of the good elements of the DASH diet, put them together, and now you have the MIND diet. There's also more of an emphasis on dark green leafy vegetables and berries, than some of the other, the other two diets by themselves. So I would say those are the two kind of major differences when you're thinking about each diet by itself versus the MIND diet combined. So they basically just looked at, epidemiologically, they basically just looked at, okay, what are the foods that are associated with the best cognitive outcomes? And they basically looked at those foods, put those foods into a diet, and now you have the MIND diet, okay? So the MIND diet, when they looked at people over time, they found that people who have high adherence to the MIND diet have much better, cognitive decline with aging. So less cognitive decline, I should say. It slows cognitive decline with aging versus those who have low adherence to the dietary patterns associated with the MIND diet. Now, you guys probably remember this study. There's obviously a lot of publicity about this study. So there has been a major randomized control trial using the MIND diet. It was published, I think, a couple of years ago, 2020, 2021, something like that, in the New England Journal of Medicine. But they looked at the MIND diet versus another diet for the prevention of cognitive decline in older persons. 2023, I was wrong. I was actually more recent than I thought. But okay, so I always show this slide to my students as kind of a cautionary tale, because whenever you choose your control group, you need to choose it wisely. Because if you see here, to me, they chose a control group that was way too healthy. And I guess maybe they were thinking, oh, look at that, look at the results in the Mediterranean diet. That diet, they chose a low-fat diet, which was considered a somewhat healthy diet, and they still showed superior advantages. But here they chose a fairly healthy diet that was the control diet, and the control diet included moderate weight loss. So this is why you're probably seeing a nice improvement in global cognition in the control diet as well, and that is not dissimilar to the MIND diet. I contend, though, that if you had to compare putting someone on a MIND diet versus the Western diet, you probably would have seen a much, this is just my speculation, but you probably would have seen a much better outcome. So why the MIND diet for stroke prevention? So this actually goes back, I think, 3 or 4 years now. So I've been chatting back and forth with Sean about what the best diet is for stroke prevention, or for secondary prevention as well. And obviously the DASH is more aimed at reducing blood pressure, whereas the Mediterranean is probably more looking at that atherosclerotic plaque development, inflammation kind of angle. So at one point I just said, well, why don't we just use the MIND diet? It kind of combines the best of both worlds, and maybe that is actually the best diet to kind of reduce stroke long term for primary prevention or secondary prevention. So that's kind of how this started. But the MIND diet highlights the key foods and nutrient profiles of each of the diets, the Mediterranean and the DASH. And so it has the high potassium to sodium ratio of the DASH diet. So through its inclusion of high leafy green vegetable intake. So this is associated with a nice reduction in blood pressure. There's also a fair amount of dairy on the DASH diet. So that also has a lot of potassium, so it reduces blood pressure. And then you get the anti-inflammatory or the antioxidant benefits of the Mediterranean diet through its inclusion of olive oil, nuts, and berries, which reduces inflammation and lipids. Today, no study has actually assessed the feasibility and efficacy of using the MIND diet specifically to treat CVD risk factors such as hypertension. So the MIND diet has been around for a while now, but it's primarily been used to look at cognitive function. So the effects on the brain and then cognition, because that's how it was kind of designed back in the day. But I actually think it could be a really, really useful tool for targeting hypertension. One of the reasons being that your DASH diet by itself can sometimes be overly restrictive. It's really hard for people, especially in the South, to hit this 20% of fat target each day. And so the MIND kind of is a little bit more liberal in that regard, and it's just a little bit more liberal in general. I would say it's a less restrictive diet. So for all those reasons, we thought that it would be really interesting to look at the effects of the MIND diet, specifically on hypertension as an outcome. And so we just finished this 4-week pilot study, and these are my 2 graduate students who are defending their dissertation and thesis respectively. Erica Zollner and Gabby Lewis, they're going to be defending in 2 weeks. So I don't want to show all their data, but I am going to just show you some of their kind of key outcomes. So we did a 4-week pilot study looking at the feasibility and efficacy of the MIND diet with high-intensity interval training, so exercise training, on blood pressure, sleep quality, and other cardiovascular disease risk factors in adults with hypertension and overweight and obesity. And so these are just some of the outcomes that we measured. So obviously, our primary outcome being a pilot study was feasibility and adherence, but our kind of main kind of quantitative outcome for patients with hypertension was ambulatory blood pressure monitoring. And then we also looked at blood lipids, glucose, and inflammatory markers. We haven't yet analyzed those. We're going to analyze those next week, actually. Changes in body comp, changes in cardiorespiratory fitness, and then we were also really interested in sleep. So we used the PSQI, the Pittsburgh Sleep Quality Index, to look at changes in sleep quality, and then we also had them wear Fitbits to track sleep throughout the duration of the study. And that's primarily going to be my master's student, Gabby Lewis's thesis in 2 weeks. So I'm just going to go over key inclusion-exclusion criteria to give you guys a sense of what the patient population looked like. They were 18 to 74 years old, BMI of 25 to 39.9, so overweight or class 1 or class 2 obesity. Clinically diagnosed with hypertension with or without current medication use, although all 10 participants had clinically diagnosed hypertension and were on blood pressure medications. No history of diagnosed cardiovascular disease or diabetes. Obviously, the focus here is more primary prevention, so we didn't want anyone with a history of cardiovascular disease or diabetes to be in the study. Physically inactive or sedentary, so we actually did a 1-week run-in, and so the benefits of wearing the Fitbit is you can actually look at, track someone for 7 days, and then look at their step counts, and if their step counts are too high, you can exclude them. But all 10 participants in the study had step counts below 7,500 steps per day, meeting the criteria of physically inactive or sedentary. And then no current injuries or illnesses or orthopedic limitations, because obviously of the exercise training component for the study. And then finally, able to read and speak in English. Now, this is probably a limitation, especially when we think about expanding these results to the community, especially the Spanish-speaking community in Houston. Definitely a limitation that we will need to address. Okay, so what is the what does your kind of table 1 participant characteristics look like? So our average subject for this study was roughly 53 years old, so middle-aged. 80% of our participants were female. About 50% were Black or African American. The other 50% were Caucasian. We had 2 Hispanic or Latino, and then we had and then you can see that BMI was in the class 1 obesity range, so around 33. And then, clinic-based blood pressure, they're 128 to over 82 to begin the study. And then we'll show you the changes in a couple of slides. And also, as you can see here, these are just some of the comorbidities and then the different antihypertensive medications that they're on. But you can see that obviously by design, 100% of participants had diagnosed hypertension, 80% had hyperlipidemia. And then in terms of the antihypertensive meds of interest, the majority of our subjects were on ARBs. Some of them were on diuretics. And then, we also had 1 or 2 on calcium, calcium channel blockers or beta blockers as well. All right, so, without further ado, what was our MIND diet intervention? So participants were instructed to consume fatty fish, 2 servings per week, berries, 5 servings per week, mixed nuts, 5 servings per week, and then dark green leafy vegetables basically daily. And then extra virgin olive oil, they did 2 tablespoons per day. And then finally, we gave them a Premier protein shake to drink as well, just because they're starting to do the high intensity interval training several days a week, and so they have a slightly higher protein need associated with that. And then in terms of limitations or the restrictive nature of the diet, and this is what I was kind of saying earlier, we weren't overly restrictive. We actually told people, look, if you want to do fast food 1 day a week, we're okay with that. Like, that's okay. Just please limit fast food, red meat, and processed meat to less than 1 day a week. And then we said sweets, including regular soda, just make sure you do that less than 3 times per week. Okay, so this is probably one of the most important slides of this whole presentation because the biggest problem with any sort of nutritional dietary intervention is getting people to actually do it and adhere to it. So what we did to kind of maximize the adoption and adherence of this intervention is we did an initial 45-minute dietary education with a registered dietitian nutritionist. And we actually gave people some of the key foods of this diet. I think that this is a very underrated quality. And if I do this, on a larger scale, I definitely will consider doing a similar kind of approach again. But we gave them mixed nuts, olive oil, and the protein shakes. We just gave them to them. Okay. So now you're removing that barrier of them having to go buy it. And then, did they actually do the diet? So removing some of the barriers. And then we also gave them a weekly stipend to purchase foods that align with the Mind diet. So they're already getting the nuts, the extra virgin olive oil, and the premier protein shakes. And then we gave them $25 gift to Target, and then they could buy, the fish, the berries, and then the green leafy vegetables with that $25 each week. So this was our goal to kind of make sure that they maximized adoption and adherence. And I think it worked because I'll actually show you some of the data. One final comment that I want to make, and I've said this before, but I think that one of the reasons why this diet is so successful is it's additive and it's not really restrictive or subtractive. I think a lot of times people get really frustrated because they feel like diets are overly restrictive, and that can be really kind of disheartening. And so I think that one of the really big benefits or pros of this diet is just the additive nature of it versus being overly restrictive. Okay, what about the exercise training intervention? What did that look like? So we had 3 days per week of high intensity interval training on the bike. And, on these, Monarch bikes that you can see over here, we did, each HIIT session was about roughly 30 minutes, so 29 minutes to be precise in duration. So they did 10 1-minute high intensity intervals. And all exercise training sessions were supervised in our lab, and exercise intensity was continuously tracked with polar heart rate monitors to obviously make sure they were hitting the correct exercise intensity goals for high intensity interval training. Okay, so without further ado, our main findings, the feasibility. So 100% of the enrolled participants, so all 10 participants who enrolled in the study completed the study. We had no adverse events reported for the exercise training, which was great because obviously there always is a concern that when you're doing either VO2 max testing or high intensity interval training that you may have an adverse event, but we didn't see any issue with that during the intervention. But the diet and the exercise portions of the interventions were well received and well tolerated. And when we were tracking adherence, what we did is we gave them these basically weekly checklists to complete. So these were the foods that we obviously were emphasizing as part of the Mind diet. So they had to fill, it's basically a checklist that they filled out each day, and then they returned the checklist to us at the end of each week. But, I'll be the first to say, who's to say they don't just check every box, right? And they lie, okay? So we also used other validated tools of tracking adherence to different diets. We also used something called the Mediterranean Eating Pattern for Americans questionnaire. So we gave that to them unannounced at the beginning of the study at baseline, and then unannounced in the final week of the intervention. And so that we could look at the change or adherence to different eating patterns before and after. And when we did that, we found that there was a really nice increase in this metric called the MEPQ. The MEPQ is just Mediterranean pattern of eating among Americans. So how closely do they align to the Mediterranean diet? And you can see here they went from an 8 at baseline to around 12 at week 4, which is basically they're going from a moderate adherence to a very high adherence by study end. And when we looked at those Mind diet, those food checklists that we gave them, we saw that overall compliance was around 92%. So really good compliance there. And then finally, one additional step, the only thing that we could have done in addition to this to really truly know whether people were actually being truthful or not would be to measure blood and measure oleic acid or other kind of objective outcomes. But another way to do it is you use something called an ASA24, and it's a unannounced 24-hour dietary recall, and it's been validated. It's shown really good validity, and so obviously NIH is really excited about this new tool that they have. but we gave that to them at baseline and then at the end of the study again. And when we did that, we saw really excellent adherence with the diet that we gave them. And the one thing that I wanted to show you, and if you have any questions about how much did, monounsaturated or polyunsaturated fat or potassium, or, you can ask me that during the Q&A. I just didn't have enough time to fit everything in. I'm happy to answer changes in food group as well. But one thing that this also allows you to do is it allows you to look at the healthy eating index score, the change from baseline to the end of the intervention. And this is quite incredible. Like, I probably get excited about this because I'm in nutrition, but I showed this to a colleague who's in nutrition and he almost did a backflip. Because if you look at the adherence to a healthy diet at baseline, their healthy eating index score, total score, was 48, which is pretty bad. Typical US diet is around 50 or 51. So we do a horrible job adhering to the dietary guidelines for Americans. By the end of the study, their score went from a 48 to almost 80. So it was 79. So, which shows a very close alignment with the dietary guidelines for Americans. So this tells you this is like additional evidence that adherence to a healthy diet was really high in this study. Okay, and then in terms of exercise training, we had 100% of participants attend scheduled exercise sessions, and then as you can see, in terms of exercise intensity during the high intensity intervals, we were around 87% in week 1, and we were around 91% in week 4. So really good compliance in terms of them meeting the exercise intensity goals. Okay, so these are kind of the main findings of the study. So we know that we had really good adherence to diet and exercise, but how did that translate into actual clinical endpoints? And so right away, you'll see this is clinic-based blood pressure, so measured with a Welch-Allyn. You can see that over a 4-week period with the MIND diet and high-intensity interval training, we saw about a 7 millimeter reduction in systolic blood pressure and about a 5 millimeter reduction in diastolic blood pressure for clinic-based blood pressure. And then for ambulatory blood pressure, a much larger effect, so around 9 millimeters of mercury for 24-hour ambulatory systolic and about 7 millimeters for 24-hour diastolic blood pressure. Now, one thing I want to also point out, in these figures, and I think it's useful, I love that, we can show the individual data here because we only have 10 participants. But one thing that I do want to kind of make a big deal about is it's not like we just have people who are starting high, like a high baseline blood pressure, and those people are driving the overall mean. We even have people down here who almost seem to have good well-controlled blood pressure on medications, and they're still seeing benefit. They're still seeing, a 5 to 6 millimeter improvement, despite starting at around 110 for systolic ambulatory. Then, the next data that I'm going to show, this is more from my thesis students, thesis that's coming up in 2 weeks. But she wanted to look at specifically, how does this intervention impact nocturnal hypertension, and how does it impact sleep, and how are those variables related? And so this is, I think, probably the most interesting finding of the study, to me at least, is, when we finished this intervention, we saw a nice reduction in daytime blood pressure, so around 7 millimeters of mercury for systolic and about 5 for diastolic. But when you look at nighttime blood pressure and you look at the individual data, it is consistently reduced. 11 millimeter reduction in nighttime blood pressure for systolic and around 7 millimeters for diastolic. And so these are pretty profound effects, and I know this data is preliminary and it's not a randomized controlled trial, but we're pretty excited about the prospect of looking at this specific finding more closely in future studies. I'm happy to hear if anyone has any comments on that during the Q&A. Okay, so mechanisms, what's driving these effects? So in terms of what we actually measured, we did see about an 11% reduction in visceral adipose tissue despite no changes in body weight. So we had no changes in body weight in this intervention, but we did see a 11% reduction in visceral adipose tissue. Now, this is pretty common, especially for high-intensity interval training. It has been shown to basically significantly reduce both visceral fat and hepatic fat, even in instances where body weight isn't changed. And inflammation and insulin resistance, we're analyzing the bloods next week, so I can't really comment on those. We did have an increase in cardiovascular fitness, and so we may have some, adaptations in the periphery, particularly, large conduit and microvascular function that could be driving some of the reductions in blood pressure. And we did see an improvement in sleep quality in terms of global PSQI score, but I should mention that I think only 2 of our participants actually had disrupted sleep at baseline, and those 2 participants were the ones that were driving the overall improvement in global PSQI score. So I think that I told my thesis student, I'm like, I would be very cautious in how you interpret this. Okay, and then for unmeasured, things that we hope to measure in kind of follow-up studies. So, we would obviously look at changes in large conduit and microvascular function. So some of the mechanisms that could be driving the improvements in blood pressure, maybe novel blood biomarkers associated with hypertension, and then sympathetics. So I'm wondering if some of this is just driven by a reduction in sympathetics at night, because that could be contributing to the major reduction in nighttime blood pressure. I did text a colleague right before I jumped on this call, and I was like, "Hey, could you measure nighttime MSNA?" And he's like, "Yeah, I think someone's done it." So I don't know. I just think it's something that we could look at in the future. So limitations, this work should be viewed as preliminary. This is not a randomized control trial, and so we're obviously very cautious in how we report this. It's only 4 weeks. What about 4 months? What about 4 years? Can they actually maintain adherence for 4 months? Can they maintain it for 4 years? We don't know. Are these improvements being driven by the mind, diet, or exercise? So one of the biggest limitations of this study is what's actually driving the bus here. And it's probably both. I mean, at least in my opinion, it's probably both. You're probably getting, I think the really cool thing about having, diet plus exercise is you have different mechanisms at play here. So, exercise training typically is associated with a major reduction in blood pressure in the hours following each training session because of the hypotensive effects of exercise, particularly the drop in, systemic vascular resistance after exercise. So, whereas the mind diet is, mediating pathways that are totally different to exercise training. So I think you're getting in, the goal with the next study will be to do a mind diet by itself and then have a mind diet plus exercise. You can look at the additive effects of exercise. And then obviously the limitation of external validity. These findings were in middle-aged, primarily white and black adults, English-speaking individuals with hypertension in Houston. I don't know if this will translate to other populations as well, but I'm really excited about this. I think this, this sort of lifestyle intervention could translate really well to stroke. We could modify the high-intensity interval training aspect and just do more of a, physical therapy-based intervention with exercise, or I think heart failure. This would work well as well. But okay, so part 2 summary. This preliminary work indicates that the mind diet and high-intensity interval training exercise is feasible with excellent adoption and adherence to both the diet and exercise portions of the lifestyle intervention. The addition of the mind diet and HIIT resulted in large, clinically meaningful reductions in both clinic and ambulatory blood pressure data, 24-hour blood pressure, in patients with hypertension already being treated with pharmacotherapy. So that's one thing that I want to reiterate as well. I mean, a lot of these patients were already on pharmacotherapy. Now you can make an argument like how well controlled or were they optimized or were they on optimal pharmacotherapy? And I appreciate that argument, but I think the point that I'm trying to make here is that, diet and exercise still have a place even in a world where you have optimal blood pressure control from pharmacotherapy alone. And these improvements were independent of changes in body weight, which again, in this era of GLP-1, I just think that this gets lost when it comes to lifestyle. Okay, finally, this is going to be the last slide, and then we'll kind of open it up for questions. But what about implementation in the clinic or in the community? So I think if you really wanted to do this well, either in the clinic or in the community, or both, you would have to have an interdisciplinary team. I think it's pretty clear. I went to a really good webinar 2 days ago or 3 days ago by Jacqueline Albin. I don't know if you guys attended that one. It was actually through UT Health, and it was all about culinary medicine and how she's implemented this program at UT Southwestern. It was fantastic. So I think that her kind of setup at UT Southwestern is probably a good roadmap for how to kind of introduce what I'm kind of proposing and maybe just add that exercise element. But I think you would need a registered dietitian, absolutely. I think the reason that this intervention was so successful was because my PhD student, Erica, she was outstanding with, dietary education. And then, you could also consider adding cooking classes, meal planning on a budget. Food insecurity is always a major problem with a lot of patients, especially, in Houston and in lower income communities. And then dietary adherence, obviously, is going to be maximized if you have a registered dietitian. And then physicians, need to refer patients to these resources and build it into their standard of care for primary prevention. And then you have to have that public health aspect. How do you actually implement this in the clinic, in the community? So people like me definitely need help with that. So, and then physical therapy, you could have kind of that KINESE, exercise science, physical therapy aspect, and they can oversee, physical activity intervention. And then finally, community partners. This is so critical as well. Being able to increase awareness and build trust in the community to actually participate in these interventions, I think is so underrated and underappreciated. So, and that's pretty much it. I just want to, acknowledge that, this study was internally funded by the Office of Research and Sponsored Programs at TW, and then also the Institutes of Women's Health. And then these are just some of my amazing students or collaborators, including Drs. Sabitz and Sharif. Dr. Sabitz is obviously on the call. So thank you guys so much for your time. And I'm going to stop sharing so I can open it up for questions. I guess I can look in the chat too. Happy to take any criticisms too, Sean.
I think there's a question from Stephanie at our School of Public Health.
Go ahead, Stephanie.
Yeah. Hey, great to see you. Thanks for the great talk.
Welcome.
It's exciting to see the results. Definitely need to connect. I can't believe it's been 6 months since we connected after your last talk. Time flies.
Yeah.
I'm just wondering, as far as outcomes for nutrition, what are your thoughts on Vegemeter? How do you feel about it? Do you think it's a good outcome, or are you like, this is me?
I would probably go more with just compliance with blood biomarkers of oleic acid and other kind of adherence metrics. Vegemeat is fine, but I mean, that's more looking at like vitamin A or carotenoids, right? So adherence to fruit and vegetable consumption. I would probably, for my purposes, I'd probably be more interested in just looking at the compounds driving benefits with the mind, and so probably looking at oleic acid, and then looking at you can also look at sodium potassium in the urine to look at how that potassium to sodium adherence and ratio has changed in response to the diet. And so I think that NIH is requesting, or at least encouraging people to have more objective biomarkers of adherence, just because it's hard to really trust people for nutrition, right?
Yeah, since Stephanie's on the call, I wonder, obviously about other neurological disorders. So I wonder what Stephanie thinks about, these dietary, regimens for multiple sclerosis, obviously, and since that's an area she works in, and so it just starts to raise questions, obviously, about its benefits across other diseases.
Yeah, I know there's one trial that was just funded, I think, last year by the National MS Society for the MIND diet for people with MS, and we've done some work on HIT for people with MS, but I think, like Dr. Tucker highlighted, right, it's the implementation, which I'm always happy to chat about too, being over in our Institute for Implementation Science. I think that's figuring out the package that we can actually put out in the community, I think is our biggest barrier. We know it works. We just got to get people to do it and find a place for it to live.
Yeah. And I mean, I think you could probably do like group physical activity, more of a group setting. That would be fine as well. And I don't think you necessarily need to do HIT to see these additive benefits to the diet already, because when you look at, and you probably know this, Stephanie, but when you look at exercise training for hypertension, the benefits for moderate intensity training is just as good as HIIT. I mean, it's not that dissimilar. So you typically see about a 5 to 7 millimeter reduction in blood pressure with exercise training interventions, and it's not really intensity dependent.
Yeah, I think I'd agree that there's a modest difference, if any. I think what we overlook too often in these exercise training studies is preference, right? Like people
Yeah.
are going to sustain what they like to do. So if we can find something they like to do, it might not be the best thing ever, right? But if they'll do it, it's the best thing for them, right?
Yeah, and I told that to our participants when they finished the study, because we were curious. We're like, well, how are you actually gonna, are you gonna continue this? And I think some of the aspects of the diet, they seemed like they wanted to continue, like, the olive oil, the nuts and that sort of stuff. But I said, what are you going to do for exercise? And they said, well, I'm just going to walk. And I said, that's great. You find something that you actually enjoy doing and do that as much as you can. The one thing that I didn't mention on the call during my presentation that really kind of struck me is, and we talk about this in the heart failure community and the impact of cardiac rehab. So people showing up, a couple of times a week for cardiac rehab, that's like an additional opportunity to kind of improve adherence for nutrition and medications. I learned that throughout this intervention. Every time they would come in for a training session, I would say, hey, how's it going? And then they would have questions about, nutrition or the dietary intervention. And it would basically be like a way for us to check in and improve adherence. So I think that the addition of the exercise component actually served a purpose in that regard as well.
There's let's see, a colleague put in a question. Well, I guess she's in a busy environment at the moment, so couldn't ask herself. But she was asking about imaging and any plans for looking at correlates or changes on imaging with what you're doing.
I thought she was going to ask me about the image that I showed and critiquing my overview of the image. Yeah, I definitely was a bit nervous doing that one, but it's a great question. And to share with everyone else, Sean and I have discussed this repeatedly, but it would be really cool to look at a larger intervention and then maybe look at some brain imaging before and after the intervention to look at something like white matter hyperintensities. But the question is, how long do those take to develop or regress? We don't know, but I mean, there's other metrics we can look at in the brain that aren't just that. I mean, there's obviously, you can look at BOLD, you can look at other metrics, obviously cognitive function. But my understanding is that when you're looking at kind of brain and cognitive outcomes, you typically want to have a longer time frame to see like meaningful changes. Is that correct?
Yeah, I mean, we're part of NIH funded cohort studies right now, looking at longitudinal change, both in cognition as well as in MRI. Let's say white matter hyperintensities certainly would be an example, but other markers of injury that are reflective of small vessel disease. So lots of good data is going to come soon, I hope, with regards to progressive change over time and how long it takes, to see change.
Yeah, I definitely will lean on some of you guys for that, because that's definitely not my area of expertise, sort of the brain and cognitive outcomes. So I'll definitely need to collaborate with some of you for for those outcomes on any sort of follow-up grant.
It's also very interesting. I mean, you show the carotid athero disease, and how that can change on a diet. So I think that's got to be followed up with more work.
Yeah, and the question again there is just, what is the timeline? Is 6 months or 12 months enough to see kind of changes in that sort of outcome? I don't know. I mean, these are definitely interesting questions. I think you probably need to do a similar study like this in a larger sample size, and have a diet only and then a diet plus exercise group, and then maybe look at it at 6 months to a year to look at additional endpoints. So.
Other questions people have? Okay. Well, what we typically do, Wes, is we make a video record, have our video recording, so then we post it onto our YouTube channel. So it gets recycled.
Great. Yeah, that's great. I'll definitely share it on my LinkedIn as well.
Yeah, and so if people have questions, should we, I guess, post your email address?
Yeah, that's fine. You can post my work email address. No problem.
Okay. All right,
I
great.
do have a quick question.
Yeah, please.
This fantastic talk, Dr. Tucker, was wonderful as always.
Thank you.
So with these different diets, so like with the mind, particularly for neurodegenerative, do they come in variations for people who are on altered diets? So softer diets, chopped diets, etc.
Ooh, that's a great question. I don't know that, but yeah, that's a really good question.
I'm thinking of like the nut aspect and how do you substitute that for somebody that is edentulous or has some swallowing difficulty but wants to adopt that lifestyle?
Yeah, like if someone who has dysphagia, especially if you're
Correct.
thinking about like stroke, especially in a patient, patient population of stroke. So
Yes.
no, that's a great question, and I don't know.
Okay.
But I will look into it and get back to you though.
Perfect. Thank you.
Yeah.
Okay, this is great, Wes. There's more comments coming through, just, I guess, offering, think about working with community health workers to improve
Yes.
participation and adherence in these larger studies of the future.
Awesome. No, yeah, absolutely. I mean, I think we definitely need that public health aspect or community health aspect as a collaborator on future work for sure.
Excellent, great. Well, really exciting and really looking forward to a lot more research in this area in the next few years.
Well, thank you for inviting me. And yeah, if anyone has any more questions, feel free to email me. I'm happy to, I'm also happy to share the slides. So just let me know.
Excellent. Thanks, Wes. Thank you so much.
All right. You guys have a good day.
Thank you.